Okay. Good evening, Mars and Sars. I will be talking to us this afternoon on the management of myopia in children. I'm sorry, I don't know how. Okay. So by way of introduction, myopia is defined as a refractive error of minus 0.50 diopter in the least myopic eye. And currently, myopia affects about 2 million people in the world, but these people are mainly in the urban areas of the East and South Asia. But in sub-Saharan Africa, myopia has been discovered to affect 5 to 15% of our school children. And a review of the literature in Nigeria reveals the prevalence of 0.65% to 31%, depending on the location and the region of school children. So what causes myopia generally? When a child is born, they're generally born hyperopic with blurry image formed behind the retina. And this is as a result of the small size of the eyes. But as the child grows, gradually the eye enlarges until the child attains emmetropia. And by this time, a retinal image a clear image is formed on the retina, and this effectively stops the stimulus for further eye growth. But in certain situations and in some children, the eye continues to grow and continues to enlarge until the child is tilted towards myopia, in which a blurry image is now formed in form of the retina, such that the vision is defective. So what are the factors that are responsible for tilting a child into myopia? And an interplay of factors have been identified to be responsible for this. First is genetic predisposition. Children of parents that are myopic generally tend to have myopia. But more importantly, a number of environmental factors have also been identified as the factors that tilt children towards myopia, one of which is the urbanization and increased near work. Also, lack of time spent outdoors and lack of exposure to sunlight has been identified as factors that can tilt the child towards myopia. And recently, the rise in the incidence of retinopathy of prematurity, especially babies that are treated with laser treatment, tend to develop myopia. So why are we discussing myopia in Africa? Because literature has shown that the prevalence of myopia in Africa is between 5 and 15%, which is relatively lower than what it is obtainable in Asia and other parts of the world. It is because in sub-Saharan Africa, we are increasingly tending towards urbanization. We have moved from our rural outdoor life to an enclosed high-rise living. More people in Africa now live in high-rise buildings with enclosed apartments as a result of increased urbanization in Africa. And increased urbanization has been identified as one of the factors that led to the myopic boom that is experienced in Asia. So gradually, with increased urbanization, Africa too is tending towards the myopia epidemic that is currently being experienced in Asia. Also, we have changing educational practices. Our children start school very early as 2 years of age. We have increased educational demand from the children. There is a need for increased academic excellence from young children. And also recently, children have increased screen time. They are more exposed to television, they are more exposed to smartphone, computers, and social media, which is not what it used to be in the past. So these changing practices and educational practices are the reason why we are now discussing myopia in Africa. Also, in a limited resource setting like sub-Saharan Africa and Nigeria, myopic epidemic can confer significant economic burden on an individual and on our communities as a whole. With increase in myopic epidemic, there is more for frequent ophthalmic consultation, there is need for increased cost of glasses and optical aid, and for those that eventually develop complications of myopia, they will need expensive vitreoretinal specialty care and treatment. Also, good distant vision is very important for learning, as Professor Adio has identified earlier. In Africa, and particularly in Nigeria, we have a lot of children that are out of school. We have significant out of school children. So when we now have the burden of myopia complicating an already existing problem of out of school children, then it becomes a significant problem in a limited resource setting like ours. So now moving on to the management of myopia. First, how do we make a diagnosis of myopia in children? We start from the history, and usually the parents complain of poor distant vision on behalf of the child, and then children with myopia are generally noticed they may have poor academic performance, they may not be doing well in school, and then the parents may notice, or the teachers may notice, that the child is seeing through narrowed eyes, and this are indication that the child is not seeing well and may possibly be myopic. So on examination, we need to use the eye contrast appropriate visual acuity meter to check the child's vision, and all children that we are suspecting to have myopia must have cycloplegic refraction, either with cyclopentolate or tropicamide, and thereafter they should all have axial length measurements as part of the examination of a child that is myopic. Also, the child should have tests for phoreas and accommodation imbalance, as this may also help in better acceptance on behalf of the child. So when eventually we have diagnosed the child to have myopia, it is recommended that the child will use the result of the cycloplegic refraction to prescribe the glasses for a child, and full myopic correction is recommended. The previous practice of undercorrecting a myope with the aim of retaining some of their accommodation has been proven not to be beneficial in myope, and in fact, undercorrecting the myope has been shown to worsen myopia progression in them. So once the child has been dispensed with myopic correction, it should be reviewed every 6 months. And at each review, the child should have cycloplegic refraction and axial length measurements. This information should be stored and recorded properly, and they are important for monitoring the child for further myopic progression. So in a child that we are suspecting to have progression in their myopia, we should consider myopia control intervention in this child to prevent further progression in myopia. And a child is diagnosed to have progressive myopia when the child has a change, an increase in myopic correction of 1 diopter or more over a period of 1 year. So when a child comes for cycloplegic refraction and axial length measurement, and it is checked at 6 months, a progression of 1 diopter or more over a period of 12 months is suggestive of a progressive myopia, and such a child should be considered for myopia control interventions. So how do we prevent onset of myopia in children? Some children have been identified to be at risk of developing myopia, and these children include children who perform intense near work, children that are born to parents that are myopic, and children with limited outdoor exposure, especially children that are living in highbrow enclosed apartments that are at risk of developing myopia. So how do you prevent such children from coming down with myopia? Studies have shown that studies done among school children in Singapore and China has shown that when a child is exposed to sunlight or outdoor activity for a total of 11 hours per week or 3 hours per day, it has delayed the onset and at times reduce the development of myopia in such children. So efforts, advocacy, and efforts by non-governmental organizations, by ophthalmologists, optometrists, to the Ministry of Education to increase the number of hours that children spend during break time or during recess as a means of preventing the onset of myopia or reducing the onset of myopia in these children. Also, advocacy must be done to on parents, especially, to emphasize the need for a balanced lifestyle. Parents need to be counseled on the need for a child to have a balance between academic work and play, particularly outdoor play. The overemphasis on education in young children, especially children that are younger than 12 years, should be discouraged. Children should be allowed time to play outdoor and to have some recess and from break. Also, teachers and school owners or school management should be counseled on the need to have anti-myopic educational environment like bright classroom, well-lit classrooms to delay or prevent the onset of myopia in children. The picture on the left is showing the advocacy or educational material developed by the government of Singapore on to educate the masses and the populace on the need for the need for children to have more time to play outdoors in an attempt to reduce the onset and the incidence of myopia in school children. Also, town planners, governments, and works departments needs to be counseled on the need to create parks and gardens when designing the layout of an estate or designing the layout of an environment. The practice of using the available land space to erect buildings should be discouraged, so that when parks or gardens are designed as part of the layout for an estate or a residential building, then this encourages children to also play outdoor and effectively preventing the onset of myopia in children. So in children that have come down with myopia, they are at risk of developing several complications and blindness from it. So some children that are particularly at risk of progression are those that develop myopia at an early age. Studies have shown that when the child develops myopia before the age of 8 years, then the likelihood of progression to high myopia of -6 by adulthood is very high. Also, children born to parents that have high myopia or that are myopic are at risk of progression to high myopia also. Children that have high academic excellence, children that are doing excellently in school and with limited outdoor activities are also at risk of myopia progression because of the intense nail work that they engage in. There are several interventions that have been developed or tried in an attempt to slow down the progression of myopia into high myopia. And these are divided into 4 interventions. There are the optical interventions that involve the use of spectacles and contact lenses, and then there's autokeratology, and then there are the pharmacological intervention that have been developed, all in an attempt to slow down the progression of myopia in children. So the optical methods are based on the principle or the hypothesis of hyperopic defocus. And this hypothesis is based on the fact that the stimulus for continued growth and elongation of the eye is as a result of a blurry image that is formed behind the retina. So when a myopic child is corrected with a conventional concave single vision lenses, images are formed, an hyperomic blurry image is formed behind the retina, and this serves as a continued stimulus for globe elongation and myopia progression. But optical method sets out to negate this hyperopic defocus at near work, such that when a child is provided with this optical method, it negates the blurry hyperopic image that is formed at the behind the retina and effectively stop the stimulus for continued eye growth in children. And examples of the optical methods that are used to effectively block this hyperopic defocus is the use of a near HAD to the conventional concave lens. So when a near HAD is incorporated into the conventional concave lens for myopic correction, a clear image is formed on the retina from a distant object, and then a clear image is also formed on the retina from the near object. So this effectively blocks the stimulus for continued elongation of the globe, and thereafter and subsequently stopped the progression of myopia. The same principle applies for a multifocal contact lens, in which a central portion provides a clear image on the retina, on the fovea for distant vision, and then a peripheral HAD is added onto the contact lens, and this causes an image to be formed within the vitreous of the retina, thereby effectively stopping the stimulus for continued globe elongation in this group of patients. So several studies have been done to compare the effect of incorporating a near HAD into a myopic correction and comparing it with children that are just dispensed with a conventional single vision concave lens for myopic correction. And these studies have shown that when a child is given a progressive HAD lenses, and as compared to a child that is given conventional single vision concave lens for myopic correction, the progression of myopia is effectively reduced as compared to the children that are given the single vision lenses. However, the reduction in myopia progression is not significant, is not clinically significant between the two groups of patients, those that are on progressive HAD lenses and those that are dispensed with the single vision lenses. Also designed are the multifocal soft contact lenses, specifically the MiSight contact lens. This is specifically designed to control myopia in children. And this MiSight contact lens has two zones, one for distant correction and the one for near. So the distant correction effectively corrects for the myopia, and the near correction corrects for the focus that occurs on near vision. So effectively blocks the stimulus for globe elongation that occurs in myopes. So when MiSight is compared with the conventional soft bandage contact lens, it has been shown to reduce the progression in axial lens growth and reduce the progression in myopic error by as much as 52% reduction in axial lens growth and 59% reduction in the progression of myopia in children. Another method for myopic control is the use of the auto-K lenses, or the use of autokeratology. So these auto-K lenses, they are rigid lenses that is worn overnight. So this temporarily shapes the cornea, the shape of the cornea. It flattens it into a plateau form, such that when the contact lenses are removed in the morning, the cornea assumes a flattened shape, and this is what this this is in place throughout the day. So these auto-K lenses effectively also blocks the hyperopic stimulus for continued elongation of the globe and effectively prevents further globe progression. So a randomized clinical trial that was done by Cho and Chung compared the effects of the auto-K lenses with the conventional single vision lenses and reported a significant reduction in the axial length growth by as much as 43% in the group of children that were given the auto-K lenses. So what are the limitations of this optical method of myopia control? The bifocals and the progressive hard spectacles have been shown not to be very effective in controlling axial length growth and in reducing myopia progression. The multifocal contact lens and the auto-K lenses are very effective in preventing further myopia progression, but however, they are very expensive and they're not readily available in our environment. And these multifocal contact lenses and the auto-K lenses carries the risk of microbial keratitis because of the close contact with the cornea. The pharmacological intervention with the use of atropine is another intervention that has been designed to limit the progression of myopia in children. And the efficacy of atropine has been established by a randomized clinical trial done in Singapore in the Atom 1 and the Atom 2 trial. So in this trial, 1% atropine was given to children every night, and then another group had just placebo, had isoteres every night. And with the group that had 1% atropine, had their myopia slowed down by as much as 80% after 24 months. So lower concentration of atropine 2 was also tried in the Atom 2 trial to see if they're as efficacious as the higher concentration atropine. And it was discovered that lower concentration of atropine, concentration as low as 0.1% atropine, are equally effective in limiting the progression of myopia in children after 24 months. And 5 years after the introduction of atropine, the myopia progression was still significantly reduced with the use of low concentration atropine. The LAMP study also compared several concentrations of atropine in an attempt to determine the optimal concentration of atropine that is effective at limiting the progression of myopia with minimal side effects. And all the low concentration of atropine that were tried are effective in limiting the progression of myopia with the most effective concentration of 0.05% atropine. So the limitation of low dose atropine is that the low dose concentration of atropine is not commercially available. So the atropine will have to be compounded from the 1% atropine with the risk of contamination and all. Also, atropine is associated with side effects of light sensitivity and difficulty with reading in children. And then when atropine was stopped, there is the possibility of a rebound increase in myopia progression. And there is no effective time to when treatment with atropine should be stopped. So in summary, the intervention for controlling myopia are either lifestyle modification in the form of increased exposure to outdoor, limiting screen time, and limiting near work, or optical methods with the use of multifocal spectacles or multifocal contact lenses, or the use of corneal reshaping contact lenses in the form of auto-K lenses, or the use of medications like low-dose atropine. So several studies have compared the effectiveness of the several strategy for myopia control, and atropine and autokeratology are shown to have the most effect at limiting the progression of myopia in children. So in conclusion, the prevalence of myopia might be low in sub-Saharan Africa, but we are also at risk of the myopia epidemic, just like what is being experienced in Asia now, because of our rapidly changing social demography, increased urbanization, and increased network in our children. There are 3 proven effective myopia interventions, and these are the use of atropine, autokeratology, and soft bandage contact lenses. However, these interventions are treated with serious side effects like microbial keratitis, making their use not popular in Nigeria. Lifestyle modification to prevent both the onset of myopia and progression of myopia is still the most cost-effective and the safest option for us in sub-Saharan Africa. And then I acknowledge the contribution of Dr. Fatima Kyari and Professor Dukbel Ademola Popola.